Mr. Hart presents to the emergency department at Hospital A complaining of shortness of breath, coughing, and a fever of several days' duration. The ED is very busy, but Mr. Hart is triaged and seen by a physician in a timely manner. The diagnosis is pneumonia, and Mr. Hart will be admitted, but there is not a bed available. Mr. Hart is a non-service connected Category 8 veteran with private health insurance. Mr. Hart presents to the emergency department at 7:05 p.m. At 8:30, the decision is made to admit him, but no bed is available. While the patient waits, nurses monitor the patient. The ED becomes more crowded with all bays in use, and other patients wait longer for ED care. At 11 o'clock, there is still no bed available. At 11:30, the decision is made to send the patient to a local hospital. The local hospital agrees to accept the veteran, and while nurses complete paperwork and calls to the receiving hospital, the MD also completes paperwork. At 3 a.m., the ambulance transports the veteran to the local hospital. Mr. Hart is admitted to the non-VA care hospital as an authorized admission. He receives treatment for pneumonia and a comorbid condition of COPD for 4 days. However, insurance approval is not obtained. After 4 days of non-VA care, Mr. Hart is transferred back to the VA. When he arrives, no medical necessity exists, yet he remains in the hospital while home oxygen is ordered for 1 day, and he remains a second day in the hospital while everything is set up for his discharge. Finally, on day 7, Mr. Hart returns home. Now let's look at some tangible and intangible costs related to this admission. 4 days of non-VA care, $9,000. Loss of revenue because of no pre-certification, $50,000. Ambulance transfers, $2,600. Loss of revenue because treatment was not necessary, $25,000. The veteran has a copay of $1,200. Additionally, there were multiple points of handoff, excessive waiting, potential dissatisfaction, and lack of trust in the VA.